We have Dr. Sheng-Po for today's speech, but he had an emergency event in his hospital, so we have Dr. Sheng-Po Hao for today's retirement webinar instead. So let's welcome Dr. Sheng-Po Hao for today's lecture.
Yeah, I think Professor Utam Sinha just contacted me that he won't be able to join today, this morning, just because he got an emergency and he needs to rush to the hospital for a emergent tracheotomy, which is totally understandable. So just try to replace him. We will postpone his lecture probably next month. However, for today, we were going to replace Professor Utam Sinha's lecture by one of my lecture, which has been designed for to celebrate Professor Chung Hwan Baek in Korea Samsung Medical Center for his retirement, which was a record about 1 year ago. And so I'm going to play the video for you. Good morning, ladies and gentlemen. This is Dr. Sheng-Po Hao from Taiwan. I'm here to celebrate Professor Chung Hwan Baek retirement. My topic today is management of oral cancer past, present, and future in Taiwan. As you know, Chung Hwan Baek is one of my best friends. We actually has been, developing ourselves into some international affairs, such as to establish the Asian Society of Head and Neck Oncology in 2008, and we have been cooperating with Korean and especially Professor Chung Hwan Baek for doing this. And his retirement for me is a big business. So I hope I could be in Seoul in person to celebrate his retirement. However, as the COVID-19 situation, I could not do it. However, I still want to talk about the oral cavity cancer in Taiwan, which is one of my favorite topics. And as you know, Chung Hwan Baek is one of the giants in treating the oral cavity cancer worldwide. So let's talk about oral cavity cancer in Taiwan. I think in Taiwan, we have the highest instance of oral cavity in the world. It is the fourth leading cause of cancer deaths among male. Every year, we have around 6,500 new cases and around 45% of the cases will actually die of the disease. As you may know, the etiology of oral cavity cancer in Taiwan is bitter nuts, chewing, cigarette smoking, and alcohol consumption. And as you know, for the male instance, Taiwan got the highest instance, which is much higher. It is a very bad reputation. And so along the years, you can see the instance and mortality rates of oral cavity cancer is increasing along the years, and then it become a plateau in recent 10 years in both the instance and the mortality. And the problem we face in Taiwan is actually, we face most of the cases were actually 34% of the cases in my practice is actually stage 4 disease. As you may know, when you face a patient with stage 4 disease, you would have a very poor prognosis. For example, we have only 78 5-year survival for stage 4 oral cavity cancer. And if we compare the 5-year relative survival for oral cavity cancer with the sheer data with the with the United States, you could find we were actually 16% behind the standard of the American. So we need to do something. So we know that the oral cavity cancer risk is cigarette smoking, alcohol drinking, and bitter nuts chewing. And then we also know that the three factors will kind of cumulative. That is, it's not 1 + 1 + 1 = 3. It's actually 123% of a chance to raise to develop a oral cavity cancer if the patient consumes cigarettes, alcohol, and bitter nuts. And we have been studying a lot on the bitter nuts. And then actually we know that the acetylcholine compound, which is a major addictive alkaloid in bitter nuts, and then in our minds, the acetylcholine would not only cause a physical addiction but also psychological addiction. It's a big problem in Taiwan. So our country, the Taiwan government, look into this, and we know that the betel nut alkaloid is a first order carcinogen. And then the problem in Taiwan is even more worse. As you could see, there's a lot of betel nuts stands and along the streets, and the girls wearing mini skirts to sell bitter nuts. So the young population would love to have enjoy bitter nuts, and then perhaps 20 or 30 years later, they develop a oral cavity cancer. So in Taiwan, oral cavity cancer, we commonly call it a bitter nuts related oral cavity cancer. And then our government really did a lot of things. For example, bitter nuts health and hazard prevention and oral screening program. And by doing expect people not to chew bitter nuts, so we kind of control the bitter nuts chewing rate from 17% to the 6.2%. So that's the initial results of the program. But then again, we start to have the National Cancer Control Program for oral cavity cancer for the people with bitter nuts, who is bitter nut chewer or current smoker or age more than 30 years old or above. Regional people, they could have a free oral cancer screening by the specialist, by ENT doctor, and also by oral maxillofacial surgeon. And then you could see by doing this, we are not only detecting some oral cavity cancer, but also we detect some oral potential malignant disorder patient who were not cancer when the screening, but later develop a cancer. So that's the target population we should watch out. And then, as you may know, that the oral cavity cancer, when you have a stage 0 or stage 1, you have around 80% 5-year survival. However, when you have a stage 4 disease, the survival dramatically decreased to around 35 or 36%. And then by doing the oral screening protocol program, we might be able to actually move in the stage 4 of disease, which is, without screening 40.5, but with screening stage 4, percentage could decrease to 37, 36%, move to more stage 1 disease. And of course, the stage 1 disease would have a much better survival. And more importantly, based on our data, we could prove that the oral cancer screening protocol could actually moving the survival. That means better. That means for the patient diagnosed by oral cancer screening, they have a much significantly better 5-year survival than the not detected by oral cancer screening. That means the public health issues, public health controlling cancer programs could actually improve the survival, especially in oral cavity cancer. Then we talk a little about the potential malignant disorders, OPMD. Of course, the OPMD, the management is for the treatment for prevention. It is the best strategy to manage the oral cancer at precancer stage to prevent its further malignant transformation. So the rationale is as the OPMD is not guaranteed to eventually transform into cancer. So the main objective of treating OPMD is to prevent its malignant transformation, and the best choice may not be complete surgical removal, but rather a good rationale for our protocol. Possible causes could be wait and see, or the medical therapy, or even the surgical removal. And so the comprehensive OPMD management will include screening and diagnosis and to prevent the malignant transformation, and by asking the people not to chew bitter nuts, not to smoke. That is so-called behavior touring, and for example, and then the medical therapy, chemo prevention, and the last, the surgery. So the screening could be done by inspection and by visual aids such as Turing Blue, MPI, or even the photodynamic diagnosis, PDD, or the molecular diagnosis, but we would not touch on this today. And so ENT doctor could also do the visual screening, not only have to be by the oral surgeon. So for example, we use a Turing Blue to stand on the patient and really help to detect a oral cavity cancer. And there's one study published by us which show that with the aid of the Turing Blue, we will be able to early detect smaller lesion and more second primaries. So, and for example, in clinical practice, for example, in the usual light, you could not really see where is the cancer. You probably could call this erythroplakia. However, you stand with Turing Blue, and that's the stand area respond to cancer. And then certainly you take a biopsy over this area to prove its malignant transformation. So the oral test, the Turing Blue, would be very, very helpful for us to identify subclinical lesions and to guide biopsy site. And of course, we could use the MPI system for detecting the oral cavity leukoplakia and to develop a malignant transformation. And we will not touch on this. And then I will talk a little about the molecular target drug development by prevention and the evolution. And as you know, the concept of the chemo prevention is actually try to detour the carcinogenesis. However, there are several compounds which has been applied to do the chemo prevention, but most of the trial has been failed. But you know, however, we know that the hallmark of OPMD for malignant transformation is actually the dysplasia. So dysplasia was an independent risk factor for malignant transformation. Knowing that we could actually do some chemo prevention and not to really prevent the OPMD to become a cancer, but actually to detect some of the lesions non-response to the COX-2 behavior and COX-2 suppression, and then this portion of the patient needs to be surgically treated. So that means we could actually use the chemo prevention agent, the COX-2 inhibitor, to suppress the dysplasia. However, if the patient did not respond to the COX-2 suppression, they are doomed to have a high instance of malignant transformation, and they really need to be surgically removed, surgically treated. So the conclusion, chemo prevention with 2 weeks of celecoxib COX-2 inhibitor can be a screening procedure to pick up cases who need definite surgical resection, and the incidence could be as high as around 38%. So by doing this, we take a biopsy, we look at the dysplasia, and then we try to use the chemo prevention, and we could actually select the patient for excisional biopsy case. And then again, the biopsy is very important routine procedure in the overall evaluation of the OPMD. It's not only to rule out the underlying malignancy, but also to assess the presence of dysplasia. And then talk about the surgical management of OPMD. The surgical management of oral leukoplakia or OPMD could be coronary excision, laser excision. We don't typically enjoy laser vaporization, or we think the laser should be used for excision rather than vaporization, so that you could have tissue for diagnosis, at least to assess the dysplasia, and which is a hallmark of malignant transformation. And so excisional biopsy with the subsequent histopathological examination is the gold standard of diagnosis of oral lesions. And so many years ago, we advocate the concept of excisional biopsy at the same time for margin control. The patient would be in general anesthesia. We excise the suspected malignancy or leukoplakia with 1 to 2 centimeter mucosal margin and with a cup of normal tissue over the deep surface, and we send frozen section and ask our pathologist to report is either this is a malignant tumor or it's a benign lesion. If this is a malignant lesion, please check the surgical margin immediately. And then that's the excisional biopsy procedure. And then we could also do photodynamic therapies. I think the advantage of photodynamic therapy is that it can be used repeatedly without cumulative side effects. And because it causes a very little scar, so it could be very useful for a verrucous hyperplasia lesion like this, or verrucous carcinoma, because it involves the mouth angle. We could do a surgery for this. However, we might need to have a reconstruction and to injure the oral commissure. And however, we could use PDT, the photodynamic therapy for this to ease the patient. So the PDT is also have a lower in treating the OPMD, although it did not really get enough tissue for the subsequent surgical pathology. And then Chong-Wan Baek, we have been very close, not only with a personal level, but also with a family level. The beautiful Mrs. Baek, this is my wife, and this is Dr. Song's wife, and we have been enjoying dinner together in all around the world. So, and then the last, we'll talk about the surgery itself for malignant oral cavity cancer. I think in year 2022, surgery is still the mainstay treatment of oral squamous cell carcinoma. And we all know whenever the oral cavity cancer is resectable, we should do surgery and then look at the pathology, low risk and high risk, and followed by radiation therapy only, or the chemoradiation therapy in high-risk group. And then the surgical principles will be the same, oncologically sound surgical resection to preserve or restore the function and reform the cosmosis. And then we used to do a lot of mandible split procedure like this, a cancer of the oral buccal mucosa retromolar trigone. You really need to split the mandible to remove the tumor. However, we also know that whenever we do mandibulotomy, they always carries complications. And so we don't really enjoy the complications from the mandibulotomy. So we try to not to split the mandible, like Professor Baek always told me they do the pull-through procedure or they do the visa flap, they will not split the mandible. But in our practice, we see a lot of patients coming with subtrismus, either because of the bitter nut chewing or because of the previous radiation therapy, and we examine them with fibroscope. And then we think we could also use the endoscope to not only for inspection, not only for diagnosis, but we also could use endoscope for surgical resection. So that is the paradigm shift in head and neck surgery from open to endoscopic. And we talk about the minimalism. In my mind, it is the modern art of head and neck surgery. We try to keep the surgery small. We try to in a very limited field, such as endoscopy. So for the oral cavity, if we consider a endoscopic procedure, we consider without labiatomy, we could use a visa flap without manipulotomy with pull-through. I think Professor Baek is an expert in this and try to preserve the mandible continuity and to avoid the complication arising from the manipulotomy. And for endoscopic procedure, usually it's in trismus patient, we could use endoscope to assist. And sometimes you could also use laser, especially malleable contact laser for So this is a typical example of very small tumor, the patient with trismus. We could remove the tumor under endoscope like this. And of course, the TORS come into the market. There's a lot of merit of the TORS. However, I think Professor Chong-Hwan Baek also agree with me that for the oral cavity or the oropharyngeal cancer, we could do transoral excision either with naked eye or under endoscopy. We don't really need to have robotics. For example, we have 35 tonsillar cancer or perform tumor tonsillectomy, radical tumor tonsillectomy, and by naked eyes without robotics, and we could have a 100% survival. And the most important thing is that we could preserve the swallow and speech function in nearly every case of the patient operated, because we don't do manipulotomy. And of course, the endoscopic robotic surgery is coming to market, but this is also rarely performed in Taiwan yet. So in conclusion, I think oral cavity cancer has been a threat for 40 years in Taiwan. In the past, we do a lot of destructive surgery and reconstruction. But for the present, we move to the so-called endoscopic approaches, pursuit for minimalism. And then for the future, I think we should look into the public health issues and do more prevention screening procedure, and to bring the late stage patient into an early stage so that we could really ease the patient. The last slide for Professor Chong-Hwan Baek. I wish you all the best. I think you should, after your retirement, you should spend more time with your friends, with me, and to enjoy golf and to enjoy the special meal like this. Thank you very much for giving me the chance. Congratulations, Professor Baek. Thank you.
Thank you, Professor Hao. We apologize once again for today's altering our speaker and speech, because Dr. Wooten Singha run into an emergent event in his hospital, so we have to postpone his speech, and we will announce the exact day for his speech after we check our schedule. So thank you. Is there any question from the floor?
Yeah, I feel
Hello,
very
Peter.
Yes, Peter, please.
It's Peter from Thailand. Yes. So even though this is the substitutes lecture, but it is great to have a chance to learn from the great experience from you, and especially the good model from Taiwan. I think as even though we are the head and neck surgeons, it's good to understand the comprehensive approach, how to control it, especially from the prevention, from the treatment. I think Professor Hao just shown us very great demonstration that how we can approach it comprehensively. So I think the screening is still mandatory for controlling, in the population level. For experience in Thailand, we have just started the screening, but we also face the problem that we know that the high-risk approach can reduce the mortality significantly. But one of the challenging is that we see more and more of the patient without the risk factors that we cannot determine and use it as a high-risk approach. And so this is also the other challenging issue that we need to find out, that how we can have the kind of finding the high risk group for the screening. Yes, and I agree with you that the minimal approach, because the surgery is a mainstay of the treatment. I think how we can do with the minimal approach. In Thailand, we have just started with the robotic, and in my center, we also sometimes use the endoscopy approach, like that for oropharyngeal and base of tongue, and this is still possible. The only limitation is approach. So hopefully we can have the device that can help we expose better. Yes, thank you very much. And also I'm impressed with the coxib to screen for the surgical, select the case for surgery for the OPMD. That's also the interesting one. Thank you, Peter.
Well, thank you, Peter Butts, for your comments. But actually, I just, we want to invite you over to Taiwan again for the Taiwan Head and Neck Society meeting. I think it's Taiwan Society meeting or Taiwan otolaryngology, Taiwan otolaryngology Head and Neck Surgery Society meeting. That which will be at the end of this year. I just got the information in the weekend, so I will talk to you later, and we hope we invite you over, and we hope you could share with us your experience of oral cancer screening and how to manage the oral cancer in Thailand, as well as some of the other head and neck topics, and even we sing a song together.
Yes, of course, my honor. Yes, I'm pleased to see you again. Yes. Yes.
Thank you so much. And back to you, Dr. Guo.
Thank you. So, is there any more question from the floor?
Well, if there isn't, then we are going to close the section, and apologize again because Professor Uttam Sinha got an emergency and he could not make it, and so we will postpone his lecture probably to June, and we would post the information on the website. So thank you for everybody, for all the participants, for your time and patience. I'm going to just give you some of the announce, or maybe Professor Guo, you could announce the next meeting for us.
Okay, so for next week we have Dr. Pankaj Chatterjee for a topic of high impact research in low resource setting. And for the last week of this month, we will have Dr. Gobi Shi for her topic, pediatric cochlear implant challenges and outcomes. So we'll welcome for all the participants to get online and to have the lecture with us together.
Yeah, we look forward to seeing all the participants again, next week and the week after next week. So thank you again and for your participation, and apologize again for Professor Uttam Sinha could not make it with us today. However, we will postpone his talk to perhaps next month, and we will let you know anyway. So thank you again, and thank you, Professor Dr. Guo, for your moderating, and thank you for everybody. Thank you. Bye bye.
Thank you.
Have a good day. Bye.
Thank you, Peter Butts. Yeah. Bye bye.